Hi everybody, my name is Gina Mattera and I am an Aramark dietetic intern, and today I will be presenting on a pediatric and prenatal case study with a focus on infant with a failure to thrive diagnosis. Throughout the presentation, we are going to talk through the case, we are going to talk about what failure to thrive is, and then we are going to walk through some of the suggested recommendations, interventions, and goals specific to this case. Starting out with the case overview, the patient presented to us was a 2-year and 6-month-old Hispanic female. This infant was born prematurely at 34 weeks gestation, and any infant born before 37 weeks gestation is considered a premature. For birth weight, she was born at 5 pounds 8 ounces, making this a low birth weight, and her birth length was 17.5 inches. Currently, she is presenting with a diagnosis of failure to thrive and a severe risk of malnutrition, and she is also presenting with diarrhea symptoms. For the environment category, she currently lives with her mother and older sister, and they are considered a low-income family, and they are receiving SNAP and WIC benefits, specifically for infant formula. So with the presenting issues, we want to ask more questions because we weren't given a lot of information. So specifically for the risk of malnutrition, we would like to ask more about her intake. We know that she is consuming something, but we don't have additional information. And then for the diarrhea, we want to ask questions like what beverages is she consuming? Is she just consuming a supplement? Is she consuming any excessive fruit juice? And if so, that could maybe be the reason for the excessive diarrhea. Moving into more of the patient assessment for her anthropometrics, currently she weighs 18 pounds and her BMI is landing right around 15, and her current length is 28 3/4 inches. The only biochemical data we were given was her hemoglobin level, and right now it is standing at 11, which is considered normal to the lower range, so we want to make sure that we are looking out for iron deficiency anemia symptoms because she is at a higher risk for that. Now we are going to take a look at a CDC growth chart, specifically the birth to 36-month point for girls, looking at the length for age and weight for age percentile. We were given 2 different data points, her weight and height at birth and her current height and weight. For both of those, I have plotted them, and you can see that she is falling under the 3rd percentile for both her birth measurements and her current measurements. Continuing with the patient assessment for food and nutrition history, the patient was recently transitioned to a supplement known as pediatric peptide. She has possible malabsorptive issues as evidenced by her diarrhea symptoms, and she eats very little by mouth. However, the mother is reporting that the child does not like to drink the formula and would prefer to eat solids. Lastly, on the assessment, we would want to look at a nutrition-focused physical exam. No information was presented to us. However, if we were meeting in person, this is something we definitely would want to look at to see if there are any signs of muscle wasting, fat loss, or if there is any abdominal distension in her stomach region to identify signs of malabsorption. And the muscle and fat loss could equate to additional signs for malnutrition. Specifically for this child, I would want to look at abdominal distension to see if there is increased evidence for any diseases such as celiac disease or lactose, fructose, or sucrose intolerances. Additionally, for muscle loss, I want to look in the temporalis region, and for fat loss, I would want to look at the orbital fat pads, the buccal fat pads, and the ribs, and this could increase evidence for signs of inadequate energy intake and protein intake. Lastly, we want to ask about functional status. So we would talk to the caregiver about this to see if there's any changes or if this child is not meeting general recommendations for movement, social skills, and things such as using utensils properly while eating or being able to walk on her own. We would want to ask some of those questions. Moving on to the diagnosis of failure to thrive. So the definition of this is when children are diagnosed with failure to thrive when their height and or weight is significantly below that of other children of similar age and sex. So I chose some of these symptoms and causes that would be more specific to their case study or to this case study, but there may be more. So specific symptoms to look for would be delayed physical, mental, and social skills. This could be things like poor socialization with other kids, lack of engagement with the caregiver. Physical symptoms would be things like walking, using spoons like I talked about before. For causes of failure to thrive, specific to this patient, may be anemia, may be gastrointestinal or malabsorptive issues. It may be complications during pregnancy, such as the low birth weight that was presented in this case, or economic problems. So they could all work together to increase and lead to this diagnosis of failure to thrive, or one may be playing a bigger role than another. So for economic problems, we do want to make sure that this family is receiving their WIC and SNAP benefits. Treatment will vary depending on the underlying cause. And for this case, I presented with a PES statement of inadequate energy intake related to poor PO intake as evidenced by less than the 3rd percentile on growth charts, low BMI, and mother reporting lack of intake. Moving on to the current caloric intake. So I just wanted to include a slide on this just to really look at what we know. So the only thing presented was that this patient is on a pediatric peptide supplement, and we don't know what else she's consuming, but based off of her percentiles, I would say that she has an extremely inadequate diet and she is at a severe risk for malnutrition. Specifically, the pediatric peptide is going to be a nutritionally complete product. However, if the patient is only consuming this, they're going to be severely inadequate in all of the macronutrients and other things like fiber. Transitioning to her energy needs, these needs are going to be increased due to failure to thrive recovery, and this may include additional specialized formulas if necessary if she continues to not gain weight. However, I calculated energy requirements based off of a catch-up growth requirement and in addition the calorie requirements from children, even though it is a rough estimate between 1,000 to 1,400 depending on the exercise that the child is experiencing. So for catch-up growth requirements, I calculated around 1,600 kcal, and protein requirements based off of ideal body weight is 13 grams of protein per day. Below, I also provided the ideal body weight calculation and the numbers for her current body weight. Moving on to treatment recommendations for the patient. So we're going to want to look at this as a team. So the registered dietitian should not be the only person on this case. We want to make sure that pediatrician and potentially a social worker is involved. We just want to make sure that the patient is receiving the best care that they can receive and also viewing it from multiple directions. So the social worker could help with things like providing enough food, whereas the dietitian and the pediatrician will help monitor growth charts, etc., things that we'll continue to talk about. We want to make sure we are managing the diarrhea because this is not helping her in increasing and absorbing her calories. So this would include potential testing for more malabsorptive issues, a referral to GI if necessary, and transitioning to a specific diet for diarrhea. So this would be a bland food and high calorie diet just to make sure we are preventing other GI symptoms from popping up while increasing the calories consumed in this patient. We also want to make sure we are looking for digestive improvements. Lastly would be caregiver education. So we want the caregiver to understand what is going on with their child. So we want them to understand what diet they're transitioning to, how this could help, and then also giving them tips for focusing on transitioning from potentially just the supplement to increasing meals and snacks. We also want to increase meal frequency with caloric dense options and reduce picky eating. So we want to provide tips to help the caregiver work through this. Continuing on with recommendations, these are going to be specific to the registered dietitian. So as a registered dietitian, we want to be monitoring the growth charts. So the pediatrician will be doing this as well, but we want to do it on our end. We want to make sure that there is a steady growth in height and weight presented with this case. We want to monitor GI side effects. Like I said previously, we want to make sure that there are no additional signs of bloating, gas, or belching. we want to evaluate dietary adherence. So if we are to prescribe a diet for a high-calorie diet and bland foods, we want to make sure that the caregiver is understanding why this is given, how to do it, and all of the steps. So how can we present this food to the child? We also want to make sure that they understand how this could benefit their child. We want to educate the caregiver on mealtime skills. So this would be things like how to introduce new foods. So we want to have repeated exposure to a similar food, and we want to do this around 1 to 3 times a week. Lastly, we want to educate the caregiver on hunger cues. So we want them to understand when their infant or child is hungry or when they are full. Looking at some of these short and long-term interventions, our main short-term goal is going to be weight gains. We want to make sure that this patient is following a high-calorie, bland food diet to increase their percentile and their weight to prevent them, from malnutrition risk. Additionally, we want to educate the caregiver on the diet, mealtime strategies, and provide educational resources as necessary. For long-term goals, we want to catch up to the 50th percentile for this patient, and we want to continue at a slow and steady growth. By doing this, we are going to monitor their weight and height using the CDC length for age and weight for age chart. Additionally, we want to increase our hemoglobin lab levels from 11 to 13 in order to prevent iron deficiency anemia from developing. Specific goals would be to increase the patient's weight, and we would like to see at least 1 pound within the next 2 months. The second goal would be patient will consume at least 75% of their estimated energy needs at least 4 days out of the week. Third goal is that patient will tolerate pediatric peptide with no more than 1 loose stool daily over the next 4 weeks. So this will be accompanied with the suggested diet and making sure that we are using the pediatric peptide as a supplement, not as a meal replacement. Lastly would be the patient will be introduced to new foods at least 3 times a week. So we don't want to do this back to back, but we do want to make sure that there is continuous exposure to new foods to increase the likelihood that this patient will be consuming enough and a variety of different foods. I wanted to include general toddler recommendations so that the caregiver could look at this. And the main recommendation is for a child to be following similar to an adult recommendation of 3 meals a day with 1 to 2 snacks based off of their hunger and fullness cues. A variety of finger foods should be offered, and we want them to follow a general healthy diet. Supplements may be needed specifically for picky eaters, and iron may be needed if they are not consuming fortified meats or cereals. Specific to this patient, if we're not seeing increases in that hemoglobin, we may want to suggest a supplement for iron. Lastly, here are some educational resources that I pulled from the CDC and WIC website. There are additional resources on the Academy of Pediatrics, and these are resources for plate ideas, for meal ideas, and other suggestions for increasing energy intake while increasing energy output. So just additional resources, and there are plenty provided on these websites. Lastly, here are my references that I used throughout the presentation. Thank you guys for listening. Bye.